Section 3. I hope you guys are all doing well as we enter the end of Block 3 and we start to approach. We can start to see kind of the light at the end of the tunnel if you can appreciate that we only have 2 weeks left. So I want to give a quick wrap up of this block. I thought, for the most part, I thought it was really good. I thought people really had some really nice clinical anecdotes that they were able to share. People dug into the literature. There's some really good stuff that people shared in Dropbox. So I would encourage you all to go back through each of the sections, Alpha, Bravo, Delta, Charlie, and look at the different pain science information that was shared, because it was pretty good stuff. I thought Adam had some good stuff. I thought, now I'm blanking, but there was a couple other people who shared some stuff. Zev I liked his 3 pain videos that he referenced. I thought those were really good. They reminded me of the other Canadian physiotherapist that I have used in the past. Patrick's last name escapes me. He's kind of a yoga mind-body guy, and he has some good stuff. And so again, good stuff. And so I would highly encourage you to go back, because one of the sentiments, I should probably dig into this, kind of going off on a tangent, but one of the sentiments that everybody expressed was that pain science education is a hard thing, or therapeutic neuroscience education is a hard thing to discuss with patients sometimes, and how you do that, and the things that you use, and the tools that you use to engage people can be challenging, and we all need to continue to listen to other people, what they use, because as so many of you aptly pointed out, each patient is different and they come from different places, and so we need to adjust our language and our speak and our stories and our metaphors so that we can try to meet them where they are. Really, that's what we're trying to do. But I kind of get ahead of myself. So just to let you know that we everybody seems to have a good understanding of this. There was some deep self-reflection, actively seeking out people, learning opportunities beyond the provided course materials, which will only grow. So continue to do that. I love that, again, that people were drawing from other sources and bringing them in. So if we go to the next slide, key points: symptom differentiation, peripheral versus spinal nerve, right? Remember that there are entrapment points along peripheral nerves, and that those should be considered when thinking about any kind of nerve pain or extremity-related pain. But we use neurodynamic testing to help kind of tease these things out. We use cervical mobility and thoracic mobility, and we try to differentiate between what is a cervical radiculopathy. We can use the clinical prediction rule that Wainer developed as a helpful tool. May not be necessarily an exact, but a helpful tool in guiding us. And we can also how we tease out those peripheral nerve entrapment points, and using neurodynamic testing to help narrow our treatment choice. We talked on pain science, deduction, and then re-education. Really, I always tell people I need to reframe your thinking. I feel like I have to do that a lot with tendinopathy, and I have to do that a lot with pain science. So both of those things I'm reframing. It's not that you're, it's you. Most people come from a bit of an antiquated place. They are coming from old science, and whether that be the patient or the physician, or what the physician has told the patient, or God forbid, even some of our PTs speak that way. And now hopefully all of us are all on the same page and moving forward. But there's a lot of de-education and then re-education that goes on. Language, descriptor, educational tools. I already kind of have mentioned all of those things that I was really psyched to see what people brought as what they used, right? And I also loaded up, I kept referencing OPTP, which is a medical supply store. I don't know, maybe you guys know about them, maybe you don't. They are based here in Minneapolis, but they are a fairly common, well-known medical distribution site, and they do offer all PT kind of products. And so I referenced their education page. That's where Adrian Lowe sells a lot of his products, all of his books and his Help It Hurts kinds of books, and then the Mosley and Butler stuff. So check those out. I've posted those in Charlie and Delta if you want to see, or just go to optp.com and go to their education link. Very good. Regional interdependence. I do want to touch a little bit on that. Again, I think I said this maybe in the beginning, but so the CPR for Minkin and I think that's a really good one. And one of the key indicators, and I talked to a couple people about this, is about NEERS, In that one, that was when NIRS was the one. When NIRS was negative, then they were going to respond well to cervical spine or thoracic spine manipulation. And I always say to people, when NIRS is negative, you go to the neck, right? Because NIRS has a high sensitivity. So when it's negative, when it's negative, you can count on it being negative. So I just kind of plant that seed in your head. Know that there's a number of examples of treating at the thoracic spine and treating at the cervical spine. Now they say, like, even there are some articles referenced about treating the elbow and at the neck and the thoracic spine. And now the question then becomes, are we treating dysfunctions in the neck? I even posted a couple of articles that said that there was, like, people with elbow pain, 70 to 80% of the people have cervical dysfunction. So then the question becomes, are we really treating the dysfunction, or are we just providing a neurophysiologic input? In a lot of these thoracic manips packages, they're not really treating anything. They're just giving them a treatment package and seeing the response. They're not finding dysfunction. They're just packaging it up and saying, we're gonna give you, it's like giving them a Tylenol, maybe a little bit longer lasting, right? It's an analgesic effect, a neurophysiologic pain dampening or pain inhibiting effect that has a significant response, that can make immediate impact, that can then have a lasting impact with carryover into their exercise program. So regional interdependence, we've again continued to learn that this is an issue, and it also is an issue in the lumbar spine related to hip and knee. And there was one, and now I'm blanking on who discussed it, but was there a relationship between upper extremity and lower extremity? I have yet to see anything that ties those two together. That's why we continue to pay attention to the literature, because you never know, there might be something that comes out that says that, but as of right now, I've never seen anything like that. So on the PICO questions, everybody for the most part, everybody was able to come up with a good PICO question. Some people just stopped at the PICO question. I wanted you to kind of dig a little bit deeper and to kind of answer the PICO question, but the PICO question is a really good tool to have. That it's a good practice skill. It's if you're an evidence-based practitioner, you should be able to formulate a good question, go to the literature, come up with a good answer, and then be able not only to answer for yourself, but then for your patient. And this might be something that you want to do, on a semi-regular basis. That you just to hone your skills, continue to hone your skills, especially something. Let's say you're treating a lot of backs, and then all of a sudden, 3 years from now, you get an elbow, and you're like, oh man, elbow, I haven't done an elbow in a long time. Well, I'm gonna do a PICO question on best evidence based medicine treating, or what is the manual therapy? Is manual therapy effective for treating lateral elbow pain, right? Something like that, or what have you. And you go dig around. Don't lose the skill of the PICO question. Continue to utilize it in the future when all of your coursework is done. Announcements for next week. Case objective exam posting discussion. I've had a couple of people who said they haven't been able to get access to the or haven't found them in Dropbox. And typically what happens again is that this was added later. It should have been added right away, but it was added later. And so if you download if you have a Dropbox file on your computer, there's a chance that it may not be there and that you need to go online and get it. But if you don't have it, please email me quickly so that I can get it to you. Because I've got it and I've sent it out to those people who have requested. And so that's due on Monday. And then I need everybody to start digging in. Block 4 starts Monday. Reading, reviewing, crafting, post. Weekend intensives. Continue to practice and utilize your techniques. Start working your action plans. Moodle status. Everything's fine with Moodle. Continue to create and save initial documents in Word and then post them. And some people posted the Microsoft Word doc, and that's totally fine, I guess, if you want to do that. But I would really prefer you just copy and paste it into your post. Any questions, please reach out to me. Continue to push yourself, continue to dig for literature, continue to ask the questions as we go into this fourth and final block. Give me good effort, don't slack. Dig into these objective cases, and then as we begin to see your thought process and based on what we already know, try to use even some literature to help support why you're doing what you're doing or why you think the way you think. And then expect everybody to get in and create good conversation for those who are posting. So see you all online, and looking forward to reading your responses to the objective information.